Good morning, class. I am recording this audio lecture probably for the third time now. As you see, I posted some of the slides that are not working for you or me, but we'll keep our fingers crossed. So I'm going to be finishing up this lecture on schizophrenia, and as we talked about, it's on a spectrum now, as we refer to it as schizophrenia. Is just a reminder that we talked about 1 month of active symptoms, 6 months duration for that meeting the DSM-5 criteria for schizophrenia has to have some categories A of delusions, hallucination, and some category B that may be the negative symptoms of schizophrenia. So both positive and negative symptoms of schizophrenia as a reminder. And so we talked about the prevalence being, 1% in the United States. And we talked about the onset, the worse the prognosis. And so you'll see that there. We talked about the theory being somewhat unclear, but we do know it's the dopamine hypothesis, excess in dopamine in the basal ganglia, but other neurotransmitters are involved as well, which means the not only the dopamine but the serotonin and the glutamate. Glutamate is considered an excitatory neuron. So that's probably the theory that rings true. We know that the concordance rate is high with relatives, biological parents. We know about the twin studies that I've talked about. We do know about lower socioeconomic status being at high risk for developing schizophrenia. So those things are really positive. Other theories like bad mothering doesn't necessarily ring true. We talked about Eugene Bueller, who's coined the four A's of schizophrenia, which we're going to talk about those four A's. We do know that even for his theory, he said that it's a serious disruption in the mind, a splitting of the mind. So it's not like split personality, but the split is between cognition and emotion, pretty much. Schizophrenia comes with a lot of comorbid conditions. We talked about nicotine dependence, and about 70 to 90% of the population are smokers and have a substance use problem. We talked about the high rate of suicidality, suicidal thinking in this population. About 50% really think about schizophrenia, but 10% that succeed. And so we're going to talk a little bit more about that later. So the Bueller 4A's of schizophrenia is the affect, associative looseness, autism, and ambivalence. And really, with the affect, we are talking about how the individual outwardly manifests their feelings and emotions. Affect is what individuals wear on the face. And so schizophrenia, usually people with that diagnosis have more of a flat, blunted, inappropriate, or bizarre effect. I mean, you can't really distinguish what they're feeling, thinking. It really is flat. No movement of the eye or no emotion that they wear on their face. And then associative looseness, a bunch of the disturbances that we're going to talk about. But that really is the disorganized thinking. It's very jumbled, illogical speech, impaired reasoning. And also you'll hear it mostly in the inpatient environment is looseness of association. Same thing, associative looseness, looseness of association. So you'll probably hear me use that interchangeably as well. And then autism, we talked a little bit about that, but I reminded you that autism was when that person is in their own fantasy world, their own internal world that really is true to them. It is faulty. It is delusional. There's a lot of hallucinations going on. There's a lot of neologism, and it's one of the examples of autistic thinking, which really going to talk to you about that later as well. Ambivalence also is that simultaneously having two opposing thoughts, feelings, emotions. That's where the person might say their mother died, but be laughing at the same time. But they can't make decisions. It's really paralyzing to the individual because they're going between two different way of thinking about something. They're often opposing views. We already talked about the subtypes, or as the DSM-5 refers to it as specifiers for the disorder. We still need to talk about the signs and symptoms, but you have a later slide for that, so I'll just add that a little bit later. Also, the course of schizophrenia, it really is acute exacerbation. And when we say that, it means that, there may be a baseline, meaning the best that the person will get. And then with that baseline, um, they have times when they, fall or decompensate from that baseline, meaning that they're having more active suicidal thoughts or delusions or hallucinations. And these are the population that we sometimes refer to as the frequent flyers. They are in and out, and so they come into the hospital. They require rapid stabilization with adjustment of medication. And so there's an increase in residual dysfunction and deterioration with each relapse. So that's important to know. So with that particular, whether they go off their medication, whether they're exposed to more environmental stressors, whatever that causes that particular, relapse, when they go off their medication or they experience some exaggerated symptoms, then it becomes much more difficult to treat. So we're going to talk about the three phases of acute and stabilization and maintenance. We really like to keep those individuals maintained, and we'll talk about that a little bit later as well. So just mention those particular phases. And the acute phase is the active phase of either positive symptoms or negative symptoms. And then, of course, we stabilize on medication. And then the acute symptoms are less severe. Now, there's a notion of the pre-psychotic phase of the illness, and it's called also prodromal phase. So in this particular phase, just think about a 12-year-old that really starts to become socially withdrawn, isolate in the room, have very few friends, maybe grades start to fail, but they're having some emotional issues as well. And they may be obsessed with something. They may be totally different in terms of self or religion. But that's the phase that actually, if the parent or the caregiver bring the individuals in for treatment, there's a theory that you can stop the progression of the illness early on. And so that's that pre-psychotic phase of the illness. As a matter of fact, I'll be talking about this 17-year-old. I'll give you very limited information because it is in this area. But, the family member brought this person in, and she tended to think that something happened in this individual's life that's making him pace at night and do various things and hallucinate. But she didn't pick up on the pre-psychotic phase of the illness because her statement was he really was a little, strange, but never to this state. And that's the active symptoms of schizophrenia. So I'll be talking about him as we move to the different dimensions of schizophrenia. So positive symptoms of schizophrenia are the presence of symptoms that shouldn't be there, where negative symptoms are the absence of things that should be there. And so when we say positive symptoms, we are talking about active hallucinations, delusions, anything from disorganized speech or, impaired reality, impaired judgment. Those are kind of the active symptoms, but mostly active as in, delusions and hallucinations, which are, seeing things and hearing things. Schizophrenia is also a complex, disorder. But, there's a lot, even in today's thinking, There is a new blood test that they see. It's called VeriPsych. It's available to aid in the diagnosis of schizophrenia, and this is a biomarker test, like a 51 biomarker test that may help with the diagnosis. But that's really rare, and it's still complicated as a result of this particular test as well. But anyway, back to these active symptoms. The person really, and I think you have a slide for that, so we'll just kind of wait till we get to that particular slide. So I just want you to think about the presence of something that shouldn't be there is negative, is the absence of something that should. The person with positive symptoms may be hostile, as we said, disorganized. So let's just go move to those slides where we have that particular, where you can make an association and not have to write so much. Anyway, when we say to alteration in the individual with schizophrenia, we do know that the disorder impacts their ability to work, impacts their interpersonal relationships with other people, having a satisfying, unifying relationship with others, their ability to provide good self-care, and this is good hygiene, keeping the room clean, that type of thing. Certainly an impairment in social functioning, and even impairment in quality of life. The individual with schizophrenia, though, I mean, oftentimes it's supportive therapy, even back to the ability to work. Sometimes these individuals may be able to work. Just as a 17-year-old that I had to educate the family. We were talking about the possibility of stocking stores at night where there's very little interaction with the other people. I had actually a young adult in Boston area who worked at CVS, and they knew her employer knew about her disorder, and she was a very good stalker of shelves during the night because she still was a little bit paranoid with that, but she was able to get the job done with some kind of relapses here and there. But so there is ability to social skills training for this population. So again, what you have with the positive symptoms, that alteration in thinking. So I'll just go over some of the things that you hear or see here. The ideas of, well, let's go back to delusions. Delusions are considered fixed beliefs. So they are beliefs that their bowels are rotting, beliefs of persecution, delusions of grandeur, all those things, but they're fixed beliefs. So the ideas of reference is where the individual may see someone who is, communicating, for example. So they're communicating with another individual. So the individual with schizophrenia may look at that and feel like those individuals that are communicating are plotting to kill them in some way. So they're referencing something that is going on in the environment to be about them. For example, I had another young adult female who believed that the blue car parked in a neighbor's driveway were, Secret Service agents. They were tracking her whereabouts. They were, wanting to, come and arrest her type thing. So she would only move during the times that blue car wasn't there. So in this case, she was a Walmart shopper, but she would shop at 2 a.m. And her community social worker was trying to figure out why she loved to shop at 2 a.m. And until I did this kind of training with them, I was like, she was probably shopping because, that was the time that she felt comfortable, less paranoid, less that people were out to get her. So that's the ideas of reference. Of course, that blue car had nothing to do with watching her or that type of thing. Could have been a neighbor, could have been a significant other that visited the neighbor, but in in a sense where she was referencing that was about her, had nothing to do with her. So persecution is actually where other people, they feel like other people are out to harm them in some way, to persecute them in some way. So that is persecution. Persecution actually also could be that they believe that their food is poison, or somebody is going to poison their food, being watched, that type of thing. Grandiosity, then, is delusions of grandeur, where there's this exaggerated or unrealistic sense of importance. They believe that they're Jesus Christ. They believe that they're the President of the United States, so grandiose. And then somatic sensation or somatic delusions are, we talked about that, and believing that something about the body, their bowels are rotting, they're pregnant, they have a baby, you know, in the uterus, whatever that they're believing is has to do with bodily sensation. Delusions of jealousy is just that. Delusions of being controlled. They feel like that someone is controlling them, someone is making them do various things. Delusions or thought broadcasting. The individual believes that their thoughts are being broadcast out as if it's on a loud, PA system in some way. And imagine that if you're thinking your thoughts are being broadcasted, then you try not to think. Imagine what you see if someone thinks that their thoughts are broadcasted out. Thought insertion also is like someone is putting thoughts in their head. And that's just simple as that, inserting thoughts in their head. And then thought withdrawal is that someone is removing their thoughts. It's being removed. And then delusions of being controlled, again, is just like delusions of control, but they really believe that someone or something is controlling the person, like the radio tower is transmitting, you know, things that make them act and behave a certain way. Um, you know, Concrete thinking is where, that's why when you do your mental status examination, think about abstractness compared to concrete thinking. And abstractness, we tend to use a proverb for to get a sense of how the patient might answer that when we're doing a mental status assessment. And so it could be people in glass houses shouldn't throw stones. Well, the schizophrenic patient would say, well, it would break. And they were looking at you like, why are you saying that? When actually the proverb means that if your house is not clean, you shouldn't be passing judgment on other people in terms of that. Or I wouldn't want to walk in that person's shoes. Well, meaning that you wouldn't want to be that person, but the concreteness of that would be, well, I probably can wear them anyway, or they don't fit me, or kind of thing. And think about how children are extremely concrete, and make that association with the schizophrenic patient. So again, the positive symptoms of schizophrenia is really that associative looseness, or where we say looseness of association. So we kind of already talked about that. So, but with that associative looseness, or even associative disturbances, we do have a lot of things that I'll explain what typically happens in that particular context. For example, neologism, or let me just say loose association. Let me just tell you what that is first. That's that loose connection between thoughts that are often unrelated. So, the person might be talking to you and there's really no association with what they are saying. It could be the bed is unmade, she went down the hill and rolled over to her good side, and the flowers were planted there. So anything like that has no connection with anything, where neologism is considered made-up words. So made-up words as kiptopsy, liptopsy, igoxy, and if you look, the person is creating those new words that has meaning to them and only them. And so it's not anything in the English language or dictionary where you can find that term. Echolalia is really, as it relates to, you know, echo is repetitive, lalia is language. So you might say, Johnny, come take your medicine. And it's really a copying of another person's word or repeating another person's word. So Johnny would say, you're the nurse saying, Johnny, come take your medicine. And so the schizophrenic patient may say, come take your medicine, come take your medicine, come take your medicine, come take your medicine. So that's that associative disturbance. And echopraxia is not here, but I just want to mention it because echopraxia, echo, repetition, praxia, praxia, is the uh, repetition of movement. So with that repetition of movement, that is, and I know I talk fast. You guys should probably tell me to slow down at some point. So, but anyway, that repetition of its motor movement. So, for example, as a nurse, even a student nurse, you're sitting down and you sit down and you cross and then you uncross your leg. Then you might cross it again. Well, the schizophrenic person may start to cross and uncross and cross and uncross and cross, but they may be in that different behavior for hours. So that is echopraxia. So that's a copying of movement. And then clang association, we just simplify that as a rhyming of words with clang association. So they associate those words by sound, and rather than meaning. So it's like the pie in the sky will die, or she cried till she died but could not hide from the ride. But it's all rhyming, and so that is clang association. And then word salad actually is just a combination of words that are put together in a sentence, but it has no meaning or connection. And so that combination of words that have no meaning or connection outside the blue market calling. So it's a sentence, but it really makes no sense in that particular sentence. So then positive symptoms, still alteration in perception. So in your care plan, especially if you're dealing with this particular population, you should have altered sensory perception as evidenced by biochemical dysregulation in the brain, as evidenced by I'm seeing things. So that hallucination, sensory perception for which no external stimulus exists. So we do have, the auditory, visual, olfactory, tactile stimulation. So auditory is like hearing things, which I have to say this is the most common hallucination with the schizophrenic population. So visual is seeing things. Olfactory, of course, is hearing things. I mean, olfactory as in, okay, I just drew a blank there. So you have auditory, you have visual, you have olfactory, and you have tactile, and you have gustatory. Gustatory is taste, tactile is touch, of course, auditory is hearing, olfactory is smell, and visual. So, but again, most common is auditory. And the personal boundary difficulty, that is the, you know, being intrusive and obtrusive in terms of that particular, disorder in terms of that. All right, so positive symptoms, alteration in behavior is extreme motor agitation, stereotypic behavior, automatic obedience, waxy flexibility, stupor, and negativism. So with that, when we have really extreme motor agitation. We call that psychomotor agitation, where there is, the individual with psychomotor agitation may be pacing or could be, just walking real fast, but it's there as agitation in some way. Then stereotypic behaviors, that repetitive kind of movement, bodily movement. The individual also, when we say catatonia, we have to think about it in catatonic excitement or catatonic stupor, as I said in class. And just deal with catatonic excitement, then you'll see extreme motor agitation. You'll see more movement. Hold on a minute, please. Okay, so I'm back. I guess that allowed you to kind of breathe too, as I'm trying to get this lecture tape fast. But anyway, the catatonic excitement again is just it really is that psychomotor agitation comes with that. So, and that excited behavior, like I said, is running, pacing very rapidly. There are a lot of more active responses to the external environment. It can actually pose a risk to others and even to the patient, because the patient can become really exhausted in that movement. So catatonic stupor then is more psychomotor retardation, and so that individual may not be moving as well. So there is slowing of the movement in that particular case. So automatic obedience is actually where the person feels like they're, kind of being controlled by someone. And that's when they pretty much will have they may actually be in feeling like they're controlled and so won't move in terms of that obedience. The waxy flexibility then is that really is, think about wax mummy when you think about waxy flexibility, but because that can be an extended maintenance of posture. And of course, this is also seen, the waxy flexibility seen in catatonic, you know, particularly stupor, in that for example, the nurse may raise the patient's arm and the patient continues to hold that position in a statue-like manner, can do it for hours, like a Nazi salute, 4 hours, or some kind of wax mummying-like effect. So then negativism then this is akin to like resistance, but may not be intentional. So the patient does the opposite of what he or she is told, and that is negativism. So it's that passive failure to do what is requested of that individual. So let's see. And so now we're talking about the negative symptoms of schizophrenia. So the negative symptoms are more A's. I like for students to think of it as like asocial, avolition, affect, apathy, anhedonia. Anhedonia is the loss of interest in pleasurable activities. Inertia is a lack of energy, you know, they're particularly the A's might have to do with, affect, Bueller's 4 A's we talked about already, where flat is immobile or blank facial expression. Blunt, it really means minimal emotional response whatsoever. And it may be reduced. And then inappropriate, of course, we talked about, just incongruent with the person that is saying something, like a man who laughs when he's told his father has died. That really is inappropriate affect. Oftentimes you'll see that in more disorganized schizophrenia, where they're laughing very easily. They're inappropriate in that way. And then bizarre affect, just odd, illogical, emotional state is grossly inappropriate, kind of thing. And again, that is more evident in disorganized schizophrenia. And disorganized schizophrenia is the worst. I think I remember saying that. Avolition is without will, poverty of the content of speech, meaning it's really lacking, in substance in terms of that. It's a reduced amount of speech. Responses maybe range from brief or one word in terms of poverty. And then thought blocking is where they believe that there is an interruption in their thought processes, usually maybe due to internal stimuli. For example, there's you notice a sudden interruption in the patient's thoughts, and the person may abruptly stop talking in the middle of the sentence. And so you might ask, what just happened? And then the person says, I forgot what I was saying. Someone took my thoughts away, and that's thought blocking. We've already talked about flat affect, inappropriate affect. So the cognitive symptoms of schizophrenia is another dimension which is evident in most people with schizophrenia. So if you see that inattention, they're easily distracted, impaired memory, they are not able to problem solve. There's poor decision making, their logical thinking, impaired judgment are involved in that manifestation. And the impairment can lead to the schizophrenic patient unable to manage their personal health, or hold a job or maintain a support system. So cognitive has a lot to do with thinking, of course. And then mood symptoms, mostly looking like the negative symptoms of schizophrenia. That's that dysphoria, that's suicidal ideations, that's the hopelessness there. That's kind of self-explanatory. So self-assessment. So how does one work with the client with schizophrenia? And this is just what this is asking. So you might, because they can be very exhausting, the patient. So there's a team approach to, diminish burnout. There's also that group supervision where that one's emotion, the schizophrenic, emotions may produce similar emotions in the nurse. This rarely happens because you have to really, but I tell you, with the family member, I can see this happening. But as far as working as a nurse with the schizophrenic person, is that you really have to understand, how you feel about working with this population. And you have to work very hard to understand that this is about the illness. It's not about you, so that you can lower your defensive behavior. Just as we, talked about the negativism and not really doing what you would expect the patient to do. So, of course, if you were going to assess this population, then you would know that the safety of the clients and others is important. There's a medical history, and you need to take. This is going to be very key to understanding, the amount of time that the person may have had the illness, 6 months. What are the active symptoms? What are all of the dimensions of schizophrenia? what are the current medication compliance to treatment? What have they been on before? What has worked? What hasn't worked? Have they been compliant? Family response and support system as well. And of course, these are some of the potential nursing diagnoses. First and foremost, you should always have a risk for self-directed or directed at others violence, because safety is paramount to this particular population. So you have to determine whether this person is at risk of harming themselves or someone else, and looking at those positive symptoms of the diagnosis as well. The sensory perception is that disturbed or alteration in the sensory perception as evidenced by biochemical imbalance in the brain. As you know, I'm hearing voices, auditory, I'm smelling things, olfactory, I'm tasting things, gustatory. People are touching me, bugs are crawling on me, as in tactile, and then I'm seeing things, as in visual. So, but again, auditory is the most common hallucination in this particular population. And also, what's the difference between illusion and delusion? I wish I was in the classroom so I could ask you that question. But illusion is something that is in the environment, that really is real in that environment, but it's being distorted. Like for example, there might be a mark on the wall that the person then sees that mark on the wall as a snake. That's an illusion. And of course, a delusion is a fixed idea. But illusions are not seen in this population as much as they're seen in the alcoholic, withdrawal, delirium. We're going to talk about later. So then, impaired verbal communication in like catatonia, ineffective coping, compromised or disabled family coping. So, what is the good outcome for the patient? Client safety and medical stabilization, and that's with the length of stay short. That's your primary focus, is rapid stabilization on medicine, protecting the patient from self or others. And then the stabilization phase is targeting those symptoms, getting control of the person's anxiety, and working to prevent relapse. And then maintenance is really some of those things that are listed here. Psychoeducation for the client and the family is important. Again, planning for that. We already talked about the safety is most important, rapid stabilization of medication, and relapse prevention in the stabilization maintenance phase, as well as education. So basic level intervention is really that the psychobiological has a lot to do with medication. We've already talked about the medication that's used to treat schizophrenia. Certainly the could be the traditional or second generation medication, so that we talked about side effects with that particular category that we want to watch out for. And I think that's later on the slide. Counseling, but counseling to the point where it works with this population, because sometimes they don't have any insight. Their world is faulty. It's as they see it. So it's working around that. And I'll get into that a little bit later. And then milieu management. Milieu management, number one priority is safety. Number two priority is decreasing stimulation. It means that it may be kind of reconstructing the environment so the person really is not overly stimulated, or putting them, allowing them to be in their room, or putting them into an open timeout, or those types of things. And then family psychoeducation. So that's explanatory there. So getting back to the milieu therapy, really, when we say least restrictive, we are talking about, and I don't think we had this conversation in class, but least restrictive is verbal communication. It is talking to the patient, trying to get a sense of what's going on. It is maybe controlling their anxiety by administering medication. So it is even least restrictive is like decreasing stimulation and putting them, in their room or in open timeout. It's kind of removing them into an environment that's stimulating them in some way. And so, if they're still acting out to the point they're a danger to themselves or someone else, it may be secluding them. So then it goes from seclusion to perhaps they have command hallucinations. And what are command hallucinations? It's those hallucinations that are telling them to act a certain way or behave a certain way. And so that may require restraints. And so it can go from 4 point restraint to a 5 point restraint, which is the most restrictive. So again, that least restrictive to most restrictive kind of restraining. But getting back to command hallucinations, the video that you watch with Jim, the horticulturist who he kept jumping off of his house, and the voices were telling him to jump, and those were the same voices that persisted, and it was all the same voices that also took his life at the same time. So that is command hallucinations. They are a particular theme. I can recall a lady that we had gotten years ago in a timeout setting. She was picked up on the Chesapeake Bay Bridge. Kept telling her to jump, kept telling her to kill herself. It was no rhyme or reason about how. So when we put that individual in the timeout room, she would charge head on, because she wasn't restrained. We were not getting to that most restrictive, but we did have to isolate her. But she would run from one end of the timeout room and to the other, which is why they're padded now in most cases. But running into starting from the back of the timeout room to the other head first, where she had sustained a injury where she started to bleed. And so then we had to put her in, of course, 4 point restraint. So that's command hallucinations. So activity, support, and structure, for these individuals. Encourage development of social skills and even friendship. So a lot of times when you have in a milieu where you have and these are intensive treatment areas, you have to have structure, but that structure is more craft activity. It is, it's not a lot of heavy duty processing because they're not able to, have good insight and good judgment at this point. They're controlled by the delusions or, the voices and those types of things. So it is kind of structuring the environment that gets to that distraction. I believe that's later on in the side, the next slide about distraction therapy, where it's music, soft music, or something that really is going to take the voices away. Hallucinations then. Hearing voices, we said, was most common. The approach to client in a non-threatening, non-judgmental manner. You definitely want to make sure that because the person, particularly the person that's paranoid, you can't like touch them. You can't hug them. So be careful of touch. The other thing for nurses sometimes is just not even to have their hands behind their back or in their pocket, because they may be thinking that there's something there that's going to harm in some way. So you have to be careful about that potential threat that might be perceived by the client. You certainly want to assess the client who may be suicidal or homicidal. And so it's simple as this. With that, the patient who is kind of, hallucinating, or they're talking, or they're saying they're hearing voices, you really need to understand what those voices are telling that person to do. So many of your responses to most standardized testing is, you can inquire about the theme of the voice. What are the voices? If you're hearing voices, what are the voices telling you to do? What are the voices telling you? Like my 17-year-old that I'm treating now, his voices are actually nice voices, and he doesn't want to get rid of them because they're positive. But it could be voices where telling the individual to kill themselves or kill other people, so you want to know about that. The biggest thing for what you shouldn't do is confirm or deny the existence of what the person believes. And I believe that's on a later slide. If not, I'll go back to that. So let's continue with hallucinations. Initiate safety measures if needed. That's about inquiring about what the voices are saying. The client's anxious, fearful, lonely, brain not processing stimuli accurately. Okay, this is where I was going with that, with the delusions. You want to be open, honest, matter of fact, and calm. Because the patient might say, "Don't you see that rat over there in that corner?" And you simply just say, "I don't see the rat. I don't see what you see." But that must be really upsetting for you to think that there is a rat in this room, but I don't see it. So you can't say, "Oh, I'll take care of it for you," or, because you didn't get it, then, like you told me you were going to get it kind of thing. So you don't want to confirm or deny. Confirm that you see what the patient sees, or deny, no, you don't see a rat. You can't possibly see a rat because a rat's not in here, kind of thing. So you don't confirm or deny. You simply say, "I don't see what you see," but if you see it, it must be very frightening. There's no man here to harm you. You can kind of validate, you are, here in the hospital, and there are people around, but the people that are around you are not out to get you, kind of communication. But don't get into a power struggle with the individual. Don't argue with the individual, because what happens is you trying to deny that the patient doesn't see or hear or whatever, you're really making them more anxious, because they're kind of now trying to convince you that their reality is real when you know yourself it's impaired. So don't even get into a power struggle with the individual. But again, you want them to describe the delusion. Tell me what you're feeling. Like you had one example on the test in the beginning when we were talking about therapeutic communication. And I think the patient walked up and said something like, "The staff just killed me." And there were responses to that. And so you can simply say, "I'm not sure what you mean by that. Can you explain that?" And so you're wanting to get to what the patient is really thinking. But, when you say, "The staff didn't kill you," it's kind of minimizing what that patient truly is feeling. So you have to be very careful about that. Again, validate part of the delusion that might be real. You are in the hospital. You are, being treated for that. People are here for the same treatment, but they are not out to get you, kind of thing. And again, we talked about associative looseness. Don't pretend that you understand what the patient is saying by responding in a certain way. That's helpful. You might say that I have a difficulty understanding, what you're saying. I'm having difficulty, and not putting it on the patient like you don't know what you're saying. I have a difficult time understanding what you're telling me. Is the better way to go with that. The looking for reoccurring topics and themes. You really want to kind of get to a good sense of what you might be hearing. Remember, we said in the beginning of class that all communication has a purpose for that individual. We just don't know what that purpose is. Emphasize what is going on in the client's environment. So, like validating what is real. Again, just don't pretend to understand what the person is saying. And that's like, "I'm having trouble following what you're saying," or you can't say you're not making sense. Just say, "I'm having trouble following what you're saying," getting back to the first sentence. The do not pretend to understand. Involve client in simple reality-based activities. Activities like, walking, activities like maybe cleaning the timeout area, or well, not the timeout area, but the lounge, involving the other patients in that. Singing or some gaming might be helpful. So, reinforce clear communication of needs, feelings, and thoughts. So, coping techniques. This is actually where you might teach them the family member, and the 17-year-old that I was talking, about is educating the family member, because again, this is the first time that they've had issues with that, and they were trying to convince the patient, and even in my office, just trying to convince this person that they're trying to help them, and they were exhausted. You can see that she was extremely exhausted. It was impacting her whole life, and she was tearful. And so I asked the patient to leave. It was second visit. I had gathered rapport with him, and I can assure you that he was much better the second time than the first time, because he was actively hearing voices, and he was turning his head to the side. And when we started talking about treatment, he got up and started to pace and become really agitated. But I had, and he said something in this environment is not right, and he was talking like that, and so I think I did a good rapport. I did a good job establishing rapport, because he returned the second time because he was resistant to medication. I don't want the medication because I don't want the voices to go away. So then we had to go into, that would help you with, to sleep, because family member said he was up walking, all night. So it will help you with sleeping. It'll help you with anxiety. So you could tell he was much better, but of course he was not 100%. So I had to go up on his Zyprexa, because that's the most the effective one for sedation and for sleep. So had to go up to a higher dose because he was still there. But the family member needed a lot of education, so I had to send the patient out to say, um, you know, to that family member that this might be the best he's going to get. So when you're trying to convince him of something, you're kind of wasting your time. Don't pull back on, getting him to do things that you want him to do, like some of those physical actions, um, like cleaning his room type thing. But don't expect great things, because you need to lose the hope that he might be any different than what you see. We can get him better, his baseline better, but so, and she had this sense of relief, like, okay, I don't have to fight with it anymore. I don't have to convince him anymore, because she was getting even I could see how that's not true. She kept saying, that's not true. I don't understand. Let it go, essentially. So, but anyway, it's going to be a long haul for him and her, because again, with this population, there's relapse often. So when we say distraction, then we're talking about having the patient, encourage the patient to listen to music, or sometimes reading out loud might help them more. Watching television, unless the television is inputting signals into their head or kind of thing. And believe me, some people hear things coming out of the TV at them. The interaction might be for kind of the family member too. You know, do they, checking if they're hearing things or seeing things, and if not, ignore the voices in the thoughts. Talk with another person, as in telling them, to help with that interaction. For example, you want them in the activity to do things. It could be if they like playing the guitar, the singing, or something that they can, channel their energy into something that's going to be a little bit more, positive, meaningful for them. Like, for example, a schizophrenic patient, you might buy, like a basketball goal to put on the outside where they can go out and expend some energy. Something like that would be a good activity. You can tell them to, if they're talking to themselves, the things that they can, check, reality checking with themselves. Social action could be talking to a trusted friend or member of the family, teaching them how to call for help, um, taking them, to visit a favorite place in the public that they like to go. So those are kind of things. Even the physical actions like walking or something like that, breathing exercises. But those are some coping techniques. I don't expect you to kind of be involved in all of this, but the big thing, the big takeaway is distraction therapy is to get them to rechannel that negative energy into something in gaming or something that can be more positive. That's the takeaway. So I think for the nurse is really to understand the illness itself. So if you understand the illness, you might know that you can't personalize some things. So even educate the family to know more about the illness. Develop the relapse prevention plan. Might be important, which know the early signs of relapse. For example, the patient may have been sleeping okay, but now all of a sudden they're pacing during the night. Um, they're doing their behavior has changed a little bit, so that means that they need to schedule an outpatient visit right away, so that adjustment of medication occurs sooner than later. Um, so know, teach them who to call, make a list of things that you want to keep with you as well. Certainly, if they can avoid alcohol and drugs, it would be better. Learning ways to address fears and losses, ways of coping. This is kind of self explanatory. Um, Comply with treatment, with medication, understanding that they might have to go on injectables if they're not compliant. Maintain communication with supportive people, um, keeping them active and healthy, diet, sleep, good sleep, all those kinds of things. Really, I don't think this is pretty much kind of. I think the one thing that's most important here is the social skills training. It is to get them involved in things that are social, those things that I mean of like rechanneling some of that energy kind of thing. Sometimes cognitive behavioral therapy is futile because they may not have insight, they may not be able to follow through. Um, so some of those things just don't work. So I think the takeaway mostly is the social skills training or diversion therapy or distraction therapy for that particular individual. Even group therapy in an inpatient environment has to be limited to a less amount of time because they're easily kind of distracted in that particular environment. So, I don't. The family therapy is mostly helping the family see the client in the best light, knowing that the disorder is impacting them more. So I don't think I require you to understand those types of things. The adaptation training though is so that the client can adapt to their environment, so the family member can um, adapt as well to the patient with the disorder, kind of thinking. Let's see what we have. So the atypical is not going to go into that, but as we're talking about, those things, you're reminded of your handout that you have that's going to go over some of these um, different treatment things, traditional, conventional. Those are the haloperidols, the flufenazine, the atypicals are like the or novel now, aripiprazole, olanzapine, quetiapine, ziprasidone, iloperidone, those types of things. And so traditional, when it says traditional, it's the older ones. I think what you need to know is low potency versus high potency. But but and to leave it, to keep it simple, low potency is sedating, but they have low EPS, but they have high anticholinergic and orthostatic properties. High potency drugs, more EPS, less sedating, less orthostatic and anticholinergic. That is what you need to know. Not really concerned about medium potency drugs, but every drug, even if you look in your textbook, you know, for example, in your textbook will have Zyprexa. Let's just look at Zyprexa in particular. So olanzapine, Zyprexa, very low EPS, high sedation, moderate orthostatic, high anticholinergic, high weight gain, high for diabetes. So, but I don't want you to, I want you to just keep it as simple as low potency, high potency. I don't want, because we can go from the gamut of diabetes, from the gamut of the whole thing. The other thing that we didn't talk about is metabolic syndrome. And with those drugs, there is a high comorbidity of cardiovascular disease in patients with schizophrenia, meaning that their life expectancy is they reduce 10 years to their life expectancy as opposed to the general population. As a result, metabolic syndrome. This is why, and then we did talk about that because we talked about checking their blood sugar, checking their abdominal girth for central obesity, checking their weight. All of those actually are, they're smoking and drinking, particularly high smokers. So their risk factor for cardiovascular disease increases 10 times the general population. So that's the thinking of, the lipidemia, hyperlipidemia, those kinds of things. So that's the metabolic syndrome. That's the cardiovascular risk. Some of the drugs we talked about, lengthening of the QT interval. So, be thinking about that. But in that classification altogether, so with this particular slide, traditional antipsychotics, they target positive symptoms. So, but if you look at the atypical, they target negative and positive symptoms. So the atypicals are not only dopaminergic, but they're serotonergic antagonists. But they have different pathways, as we talked about. So if you see, we're not going to talk about the different pathways involved, but the key to atypicals is they diminish negative as well as positive symptoms. That is the key. Disadvantage, of course, weight gain, metabolic abnormalities, as we already said. So those are the first line antipsychotic treatment, those atypicals. Atypicals, again, are olanzapine, quetiapine. So olanzapine is Zyprexa. Quetiapine as Seroquel, ziprasidone as in Geodon, aripiprazole as in Abilify, but that's considered third generational, iloperidone, which is in Vega. So it goes on and on and on. This is the, again, antipsychotic, so review this. Again, don't have to worry about the medium potency as you see here. Again, this slide is very important. Decanoics are the long-acting injectables for the traditional Haldol and Prolixin, or haloperidol for phenazine. Atypicals are listed here. Those are the ones that I was saying. Oh, don't forget clozapine, clozaril. And anticholinergic symptoms, you should know those by now, but you'll see some of those. So think about that. Think about medications have inherent anticholinergic properties, but they also, so antipsychotics and antidepressants, as you've heard, inherent anticholinergic properties. So taking, two medications can increase the risk of anticholinergic toxicity. So think about that. And anticholinergic toxicity, you're going to see more central nervous system disorientation, those types of things. Again, side effects of extrapyramidal side effects are those that we talked about in class. I'll go over it again. Acute dystonic reaction, stiffness, Neck stiffness, very dry, sluggish. Epistotonus is that contraction, a complete contracting of the body, whereas oculogyrus crisis is the eyes rolled up in the back of the head and only you can see the white of the eye. But that's a serious reaction. No one should get to where you're seeing epistotonus and oculogyric crisis. Akathisia, most common but unrecognized because, again, you'll have subjectively, I feel like something's crawling inside of me. They're pacing, they're more agitated with akathisia. So also look at your sheet to know what you should do for treatment of those. If we're talking acute dystonic, we can get rid of that reaction by doing an injectable of benzotropine. I would jump right to, as opposed to Benadryl, with the epistotonus or the oculogyric crisis. So treating that right away with medication. Where akathisia, you're going to have to reduce the medication, give beta blocker and perhaps a benzodiazepine. Tardive is here, that abnormal involuntary movement. That test should be 0. You should not, you should do it every 3 to 6 months. You should make sure that you see no abnormal involuntary movement because we said it may not be reversed. If we catch it early on, it is reversible. Tardive dyskinesia, as you have on your sheet, long-term use, high dose, elderly, over 40, more prone. So the alpha blockade or the cardiovascular effects, the postural hypotension, the tachycardia. Anytime you have the blood pressure drop, you're going to have the heart rate go up. Hypertension, so some of the drugs have the cardiovascular effect, like the the MAOI inhibitors, Nardil and Parnate. We've already talked about agranulocytosis. We talked about that, particularly with Clozaril and the cholestatic jaundice, actually with Clozaril as well. You can expect to see that. Neuroleptic malignant syndrome. Talk about that triad of high fever, altered mentation, and motor symptoms are common, but a fever in all cases of that. So that you see there. Let's see.